Welcome to this vital panel discussion on strengthening drug abuse response in India, organized by Voice of Healthcare and supported by ThermoFisher. Today, we bring together leading experts to explore scalable, evidence based solutions to substance use challenges in India. As drug abuse patterns evolve, we must also change the way we tackle these, spanning early screening at the primary care level, digital tools for clinical support, and community based rehabilitation centers. Policies need to be prioritized for long term recovery. This panel will dive into practical strategies, systemic gaps, and innovative models that can transform addiction care across diverse settings. We look forward to a rich, action oriented conversation. Join me in welcoming Dr. Ravindra Rao, Professor Addiction Psychiatry, NDDPC AIIMS. Welcome, Dr. Ravindra. Dr. Prabhat Chand, Professor of Psychiatry and Addiction Specialist, NIMHILS, Bengaluru. Welcome, Dr. Prabhat.
Thank you.
Dr. Rajesh Kumar, CEO, Society for Promotion of Youth and Masses, New Delhi. Welcome, Dr. Rajesh. Dr. Rakesh K. Chadda, President-elect, World Association of Social Psychiatry, Head Psychiatry, Amrita Institute of Medical Sciences. Welcome, Dr. Rakesh. All right. To start with, I'll put my first question to Dr. Ravindra Rao. What are the main difficulties in using the same screening methods for substance use across all primary healthcare centers in India?
So thank you for having me, and good that we are focusing on an important topic, which is creating a major public health issue in the country and even worldwide as well. So, coming to your question, answering your question, one what we need to understand is that the concept of substance use and substance use disorder is not a uniform concept. It's not as if a person once he's taken a particular substance, he has become addicted to or dependent on drugs. What we also need to understand is that dependency is one aspect of the disorder that is caused due to use of substances. There are many other associated conditions, like, for example, we have harmful use of substances, substance intoxication syndromes, those also are there, and host of other conditions. So the substance use disorder itself is a complex issue. So to screen for substance use disorder then becomes equally difficult. The second thing is that substance use itself is not one single substance. We have many categories of substances that we have, and the effect of those substances, either the acute effects or even the use of long term and the consequent withdrawal, etc., that happens because of the use of these substances, they are quite different. So, for example, alcohol will behave in a much different way than compared to, say, a cannabis or, say, methamphetamine or a MDMA. So, the spectrum of substances that are there are quite different. And day by day, we have more and more newer substances that are coming into the picture and which people are using, and the consequences of those substances are quite different from the traditional known substances that people have been consuming till now. So that is one complexity in screening for substance use and substance use disorder. The other complexity is to do with the lack of training and know-how. So people do not have adequate knowledge, and this knowledge is not imparted in their undergrad schooling. So either be it among medical professionals. So in MBBS, psychiatry itself is a very small subject that is touched upon, and addiction hardly does anybody teach about addiction or addiction treatment per se. So that becomes another challenging where screening becomes difficult because they are not aware. And what people are not aware of a particular phenomena, they also start having their own myths and misconceptions. And with addiction and with addictive substances, there are a host of myths and misconceptions which also act as impediment in screening for substance use disorders. So, for example, one thing is that as soon as you hear the term addiction and a person with addiction, you start thinking that these are dangerous people, somebody who should not be associated with. These are people who are antisocials. They are chronically, they tell lie all the time. They will not tell the truth, come what may. right? Also that they do not want to stop taking that substances. They do not want to take treatment. They do not want to get better. So if that is the case, then why should somebody be even asking any for substitute? So that also becomes an impediment to this one. And also people think that anyway this person is going to relapse, and we know that relapse is a part of substance use disorder and addiction per se. So if there is relapse, then what's the use? What's the point of spending my time on him and screening and asking him about substance use and substance use disorders? Those also are issues. Another thing to do with screening is once again this nihilism comes because anyways if I screen, what's the use, because treatment anyway is not available. I do not know how to treat, or I do not know where to send this person to. So because of lack of availability and accessibility to treatment, that also becomes a makes a person or the healthcare provider think what's the use of it, right? So all of this act as barrier or impediment to screening per se for substance use and substance use disorder.
Right. So first we need to understand that relapse and withdrawal symptoms, these are integrated, whenever somebody's using any, for that matter, alcohol or any other drug. And we need to understand that we should be educated. And if we want to seek help, we should be motivated. And education is definitely the way forward. And that will lead to more of screening and more of use of all the facilities that are available. So my next question goes to Dr. Prabhat, that what are the opportunities and limitations of using mobile apps and AI tools like Addiction RX in clinical decision making for addiction care?
Let me thank Boys for Healthcare and Dr. Vaishnavi and your Manisa. Uh, regards to Dr. Chadda and thanks to Rao. I think the challenge that Rao mentioned is that look at the surveys at the countries. You're looking at 70 to 80% out of 100 people that have no access to care. I mean, even diagnosable illnesses, alcohol addiction, tobacco addiction, opioid addiction, and many. And now the behavioral addiction, another stream has come. Now, if you don't have access to care, and whole lifetime, how many people are going to train? I'm working in medical school, like Rao and all. You have 30, 20 residents coming out, and many of them don't stay. The challenge 10 years back was that can you upscale them at least one level? Mobile labs are not a solution for teaching, but can you upscale a little ahead? Actually, it went reverse. So 10 years back, we started online program when sort of I took a fellowship in the US and came back. But then I realized, online is not possible. I mean, waiting list is 6,000, 8,000. I mean, it's ridiculous denying people to learn. And that's the reason I think in the 22 when Harshvardhan, the health minister, and he released a book called Standard Treatment Guideline for Substance Use Disorder from the ministry. And on the meeting, I told sir, can you have a sort of small app and so that it can be updated easily, because books, as you know, government fund comes and goes, writing a book is tough. I know many of our colleagues. So the book is a collaboration of AIIMS, PGI, and ourselves. Dr. Pratima, Dr. Anju Dhawan, they've led a team. I developed the app part, and that time COVID was running. So I thought let's start the app part. I mean, I'm not a tech person, but somehow I learned it, I did it. Now they're coming to app analytic, because the advantage of app is there is informative care. I mean, at least if somebody is looking at the app, it doesn't look differently. So he looks at the app and look, okay, this is a written for the person with injecting drug use and Hep C. Let me follow the protocol as it is. Because obviously cannot go to a book and search a book and come back. Somebody comes to, I mean, today morning actually I had somebody, I don't know, it's from OST Center of NACO, who actually sent a chart to me. In the app has a chart, Monday and Saturday live chart. So doctor is asking me, the person has taken something at night, so what I should do now. So you connect to the people in that you have some set protocols and you have some standard guidelines. Now, those are advantages of an app. Fortunately, app is somehow, I'm not really hugely successful, but at least look at analytics. People are spending 28 minutes in the app. 377K interaction happened in the app in last year. 130 countries are using the app, and so obviously active users are still less. But again, these are the knowledge app. Nobody uses knowledge app like WhatsApp or Facebook. You can't replace them. But at least this happened, and probably you are reaching some position, at least among the healthcare providers in the ground level. They're finding some usefulness. We have not studied till now because it took long time for iterations. 18 revision happened in the app, and it takes time to develop app and sustain it. But my own thing by looking at the analytics data from backend, definitely people are using it. Now, how much it is changing the practice, that probably you have to figure out in the next 2 years down the line and do a study. This is where this whole thought came, and the advantage of having app is that you can change it at any time. When a new molecule comes, I recently did it for behavioral addiction. I just thought gaming and gambling is increasing a lot in the clinics, at least where I work. I thought, can I put a little bit about internet gaming into gambling, and as your systems are changed, and it's on, it's up and it's moving. So this is how it's started and going on. Thank you.
That is great. If we have something, which is app based and we can learn from that. And definitely when you can change the, evolving substance use or gambling, the way you have said, that how it is impacting the society and the young people, we can definitely take steps to improve it. So, Dr. Rajesh, how can peer led and community based models be scaled to support long term recovery in marginalized population?
Problem is, we all have a data, and that data cannot be easily, understood. Like our organization SPY, we have been working with the children, women, homeless population, children in conflict with law. So the number is there, but the problem is how to reach out to X number of people in the shortest possible time. And peer-led intervention is one intervention which was designed over a period of time. Things keeping our one center which was a conflict, children in conflict with law. So we learned from them, and then we designed it, and Government of India has taken it over. So one peer, and this whole peer-led intervention is not for sustaining recovery. Please, this is vulnerable children, those who have been using drug or those who have started experimentation with drug. It is primarily for them, and maximum what they can do, they can link this individual with the available services in different part of the city. So I think this program is now being implemented in 32 or 33 districts by Government of India, and this is successful, low cost. It's a one-time investment, 120 hours, and they move on to other area. So this is one. Another is the peer-led intervention. What we have started also in school, there is a module called Navchetna. Now, Navchetna was again developed by us, and now Government of India is implementing in different part of the country. I think all UT and states are implementing it through the SCRT system. There also the peer-led intervention has been introduced, and every child who has been trained for particular hours, they are forming a group called Prahari Club. That is the initiative of Government of India, Ministry of Health, Ministry of Home Affairs. So we are trying to link peer education with education, means not preventing, educating about the drug, educating about the life skill, educating about the various opportunities available for them. And other is those who have started using drug. For them, that's a peer-led intervention. Now Government of India calls it a community-based peer-led intervention. And similar program we have started, but we are not very successful. That is for the homeless population, and we are partnering with AIIMS at one center, but we have to go a long way. So these are the things for the peer-led intervention at the community level.
Right, so I think your initiative, Nav Chetna, and others, how you are, starting the community-based programs, they are really commendable, sir. So, Dr. Rakesh, what strategies rooted in social psychiatry can be used to combat stigma and enhance community participation in addiction recovery efforts?
Yeah. See, first we need to understand that the person who is using drugs, he or she should come to the for seeking help. Now, one important aspect here is that drugs have been a part of society for centuries, or say I would say millennia. Like alcohol, tobacco, they have been a part of society, social practices. Cannabis has been part of many religious customs in India, which goes back to thousands of years. So that's one thing. So at that time, I think the bad effects or adverse effects of these were not recognized. Now, in last say starting from 60s, that we started coming to know that alcohol leads to lung cancer. Alcohol leads to that is in 70s leads to cirrhosis. From tobacco, the studies of lung cancer and chronic bronchitis and respiratory illnesses they started. So and these lead to dependence. And then 80s we saw the emergence of opioids. 70s it was cannabis. We had a very famous movie uh, uh, by Devanand in early 70s, and they had a famous song Damarodam, in which he highlighted the problems of substance use. So here there are two things in the society. One is that drug use is not considered a medical problem; it's considered a bad habit. Second thing is when it's there is a stigma attached to it. The third thing is that the governments promote sale of alcohol, sale of tobacco, and that's universal all across the world, all countries. So these are the and there is a kind of this is a very odd thing. At one stage, one side the government spends a lot of money on treatment of alcohol-related problems, tobacco-related diseases, and at the same time it promotes. Now in Delhi and NCR, we see there are big showrooms selling different kinds of alcohol, branded alcohols, and there is often the increase in the timings for sale, late night hours, 24 hours. So there are so many things which are happening. So, so this is a kind of very odd thing. But now, coming to the social issue, it's a medical social problem. I would say it's a medical problem as well as social problem, considering that it carries stigma and people are don't consider it as an illness. Those who consider it illness, they feel stigmatized to come to the for the seeking help. So we need to raise awareness, repeated awareness, starting from the early years, starting from the say early school years, that these are the medical there are medical complications. Is that it's a kind of illness. You should stay away from the drugs, and so that is one is public education. That's second thing is if this problem starts, it can be helped. The person can be helped. So person should go for the treatment, and definitely as Prabhat said that we have very limited. There's a large treatment gap which goes to the extent of 80-90%. And now there have been very many important steps which have been taken by the Ministry of Health, Ministry of Social Justice. NDDTC has been a pioneer in expanding the services, bringing service to the community. And so with the addiction treatment facilities, ATFs, and drug treatment clinics, which was started. So and state governments have also taken steps. So uh, there are two things. One is removing stigma, spreading awareness that this is an illness which can be treated, and the increasing the treatment facilities.
Right. So we need to understand that definitely there is a stigma around it, and it's like basically it's a social problem as well as it's a habit forming problem. It is not only a medical problem, and we need to address it that way. Then only we'll be able to combat all substance use. Right, sir. So my next question goes to Dr. Ravindra Rao. How can integrated care models be adapted to ensure continuity of treatment from detox to long-term rehabilitation, especially in public health systems? So please unmute yourself.
Sorry. Response to your early question, I was discussing about many myths and misconceptions that are related to substance use and people who use substances. Similarly, when it comes to treatment, there are many myths and misconceptions as well. So people believe that treatment is possible only when the person is put behind he's rested within the confines of four walls, either in a rehabilitation center, inpatient treatment, or at worst being incarcerated or in prison. Right? So it's a myth because many people are able to be treated on outpatient basis. So in an outpatient basis, provided you have the right kind of armamentarium with you, the right kind of medications, the right kind of skills, you'll be able to treat patients in outpatient basis. Few of them will require, of course, inpatient care. Now, inpatient care also doesn't mean that you require months and months of inpatient treatment. Many patients can be maintained on inpatient, can be stabilized in inpatient setting for a couple of weeks, and then the outpatient treatment can be continued for the patient per se. The second issue also is that people think that medicines are required only in the initial phase, and on the long term, pharmacotherapy is not required. What you require is essentially counseling. In fact, any person, any family member who brings their patient to us, the first thing they say, sir, iski counseling karao. So thinking that it's only counseling which helps the patient, right? Or isko center mein bharti kar do. We can understand the kind of misconception that prevail in the society. So at our center, for example, we at our National Drug Dependence Treatment Center, which is part of AIIMS, uh, we treat about 150, 200 patients. We have footfall in our outpatient department every day. And then we have at least 4 community clinics located in various parts of the Delhi, where it is purely outpatient based treatment. And we have a small inpatient unit compared to the number of patients who come to us. And we have been able to treat those patients with a fair degree of success, so to speak. Right. So this pyramid of service is something which we need to understand. Unfortunately, in India, the availability of treatment is actually the opposite of the pyramid that is there. So you have these rehabilitation centers, especially private, unregulated ones, which mushroom in every city, even town for that matter. And there people are forcibly then hospitalized, or I mean, they are kept in these rehab centers. And there many physical abuses, human rights violation happen in the name of treatment. And as a result of it, then that creates a vicious cycle where a person then doesn't come forward to seek treatment when he relapses the next time, or it already deters other people. Right? For example, if in my outpatient care, if I advise a patient that please get admitted, he'll be afraid. He said that नहीं sir, center में भर्ती नहीं होना. So because they think that center में भर्ती का मतलब है that he will be tortured, he will not be given food, he will be punished, so on and so forth. So this stigma towards treatment also is something which needs to be removed. Uh, the expansion of treatment services is something which is very important. That is something which can be possible, which can be made available, both in the government sector as well as the NGO sector. So, for example, in government sectors, Professor Chadda talked about addiction treatment facilities and drug treatment clinics, which are now being scaled up by the government in a decently faster pace, so that many places where such facilities were not available, they are being made available. Of course, the Ministry of Social Justice and Employment also was supporting the Integrated Rehabilitation Center for Addicts. Dr. Rajesh from SPM has been doing such an aircraft for such a long period of time. So those things are there. Very few people will require those rehabilitation services, which are provided by and large through the NGO sector. So close coordination between the GO and NGO sector is something which is very important for providing an integrated care of services.
So I think that's a very good message that not every addiction requires admission or, going to the rehabilitation center. They can be addressed in on OPD basis, and definitely counseling is a part of, the addiction, but pharmacotherapy may also be required. Right, sir. So, Dr. Prabhat, how can digital learning platforms be scaled to train non-specialist healthcare workers in early detection and intervention?
Thanks, ma'am. Thanks, Dr. Ravindra, to put the set in the field. So I think, as I mentioned before, so I think these are the sort of maybe 2010, 10, 11, what used to happen that point of time. Many of us, including Dr. Rao, team from AIIMS, who's been actually doing a lot of capacity building, we used to go to different places. Like you'll call the doctors, come, you will train here. So they'll come and 1 day, 2 day, 3 day, 4 day. This is happening. Second, what is happening at Nimans, we'll go to each districts of Karnataka, like a couple of people, and half a day when doctors comes for their meeting, from the district to district center, like tuberculosis. Each district has a district training centers for TB, HIV, and stuff like that. Some 10 years back. So we'll take half a day and tell them, look, this is alcohol, this is nicotine. If somebody comes in drunk driving, so educate him a little bit. Somebody fall when you're doing a dressing, you treat. Third point that sort of hit us was, so when you see the OPD, I was seeing a boy who has cannabis and schizophrenia, and he comes from Calcutta with the family to meet me. Now then I realized, can it possible to make a Xerox of mine? I sort of Xerox, not little Xerox. You can replicate faster and do exponentially. You cannot do the pace that you are doing now. I mean, 1, 2, 3, 4. Each of us work in a clinic. You have enough people in thing. That's the reason sort of there was an advertisement for the Fulbright, and I applied. Can technology be used? And that's why I went to US and got sort of ideas. And that's exactly the same time Eric Wan was started Zoom. I was there actually US when Eric Wan left Cisco and started Zoom. And we requested, can you give us free Zoom to us? So then 2012, we started the first program, and I have to convince my director, see, sir, everybody can join in one shot, because institute work, you have to, the boss has to agree for that you are doing some good job. So then that's actually started the whole technology part. Then second question is that how do you train people so that they believe that what you do it? So it changes the term training to mentor. So you are a coach. You are mentor the people that are training. Training is, training is training. So then we realize that how I learned, or many of us sitting here learned, by discussing cases with our seniors, in the institute. We thought each session will have a case. So you present the case, the people like it, similar stuff, like 30 people join. Each of you should discuss one case in one session, anonymously, obviously because of privacy reason, and let's learn from each other. So we call all teach, all learn model. So nobody is teacher here, nobody is teaching anything to us. We were very skeptical at the beginning. We thought people will talk to us. Somebody thinks the language is issue. Can I speak English? Work okay. But then we started it in 2013 and did a study in Bihar. And 17 Bihar started the prohibition. If you know the first of the government, current government. So that time Bihar government told all the doctors, एक भी पेशेंट को मौत होना नहीं चाहिए, सबको इलाज कर दो. And doctor scared. I mean, look, we have never trained in alcohol, and you are talking all these things. And some email came. We did same thing. And 6 days they came to Nimans. Some trend, some sort of discussion happened. Every week, then they present the case from the Bihar. And that time the 4G just came to market, and everybody's a phone and to connect. And we did a study, and we found out 85% of people with alcohol disorders are treated by these doctors. It's published in the Indian Medical Research. Only, I think, around 12% has to be referred to a district, higher private or district hospital. Now it means if you train, if you mentor someone, handhold someone, and be behind someone when the crisis is there, then it's possible through this digital medium. And that actually opened our eye. The digital medium can be used for then different condition and all. Fortunately, then the health minister in 2018 actually gave a grant, and it become upgraded to Niman's Digital Academy. So then it inbuilt to the system, because you can't run like a project or sort of run a fund. So now it has been expanded. There are some staff and all, many states. Then Chhattisgarh came to picture. Chhattisgarh is a state where you don't get internet easily, and one of the heavy alcohol consumption state, Chhattisgarh, specifically belt. And their amazing result came up from there. And then slowly you realize why people listen to you is because they love the discussing the case. They love that, and they see when they implement, then patient improves. They just come back again, told that, okay, sir, I did something and patient improved. This is where digital medium came and sort of started. Then I think we realized that we can't handle alone. It's impossible. It's just not right also, because language is, so you go little down and you have to teach Marathi or different language. Right? Then we started centers to look at LGB, RMH in forgot the name, in Assam. They started their own academy. Then you have Ahmedabad. We just assisted them. We did it by ourselves. They started own digital training. Orissa is doing own training, and actually invite many people, many states. We told you develop it, do it. You know the need of your place. We will tell you how to do it, and how people will, why you should do it, and how to do it, and how we have done successively so many cohorts thing. Then towards mid of 2017-18, Nieman started giving a course name, because when you ask the brick mortar university to online course, they become panicky, and that COVID actually has helped us a lot. COVID actually made it like powerful scale up. Then the moment it becomes some accreditation, some sort of dignified thing was given, and then Google started, and some of the states are using these online sort of certificate sort of thing for them to be giving some increment, employability. Many private sector came in the picture. And here we now in 21, sorry, 23, 24, what actually the problem we're facing, we are over supply, over demand is so much that then we have to decide that look, let's do a two-step process, make the pure e-learning available to everyone, irrespective of who are they are, student, private, government, doesn't matter. They finish the pure e-learning, very basic knowledge, uniform stuff, then you invite for the live lesson. So this is where we're thinking about it, but I think we need lot of centers to scale it up, and lot of hub who knows how to do digital. Digital is always tougher to do actually than doing in class in the.
Right. So I think digital media is one thing, especially the Zoom, which you are saying is a good tool. This is how you can train more and more people. More and more people can join and be told about what this substance abuse is and how can be overcome. So, Dr. Rajesh, what are the key policy gaps that may need to be addressed to strengthen community-based rehabilitation services?
Uh, let me refer to what Dr. Prabhat has said about Bihar, and then I'll link with the policy. See, the policy of prohibition in Bihar has created huge havoc. Around 5 lakh people are in jail in Bihar, and minimum punishment or maximum punishment is around 10 years. A person who is using gaja or person who is using smack can get one-time immunity. But a person who has been caught with alcohol will go to jail for 10 years. Look at the family situation. Majority of them are poor. Majority of them, those who have been the bread earner for the family, they are now in prison. And in fact, most of the district courts, including Honorable High Court of Bihar, what they are saying is that we deal only alcohol related cases. We have no time for others. So this is a policy mismatch, because when this was being implemented, we had cautioned them. I said, look here, I used the word which was very derogatory. I said, don't become Taliban. So one morning you say that, okay, and since they have been promoting alcohol in past, and virtually every village they wanted to sell alcohol, and globally, if you want to bring down the sale of alcohol or consumption, you have very set design. Like for example, you will not sell less than say 500 ml, or you will not sell less than certain amount of bottle. So there they started selling in pouch. So initially they promoted it, and suddenly when the people became dependent and government could not handle it, so you close everything. And please understand, Bihar has 4 open borders: Jharkhand, Bengal, UP, and Nepal. And there are still trains which carries only alcohol, nothing else. So this is one very important, which is the policy. So when we are implementing policy, we should be very clear. Number 2, now it is the world of chemical drug. By the time we understand that, okay, how the protocol could be developed for opiate, how protocol could be developed for other illegal drugs. Now the chemical drug. Now our problem is how to address chemical drug, and chemical drugs are being manufactured, in a small room. Like in just last 1 year, 4 factories in Noida have been raided. So policy is this very important. Number 2, we always see a drug user in isolation. We always forget that this drug user is part of a family, and especially since we work with mostly young population, they say, "Mera bacha kab tak dawa lega?" See, they want this child to recover and get back into the life, get integrated back in the society, get integrated back in the family, start going to school, start going to colleges. So this is a big challenge we as a service provider we face. So this is another big challenge. The third big challenge is, there's a huge demand, and as per the AIIMS and Government of India survey, I think it is around 6 crore people are dependent. If they need treatment, where are the treatment services available in the country? Very few. And that is the reason large number of private centers, and Dr. Ravindra has what he has mentioned is absolutely correct. that the centers, the person who has been treated 6 months back by us or by someone else, they start a treatment center, and we call it now a torture center. So there is no regulation, there is no quality assurance, there is no quality control. And now our problem is, the mental health, mental 2017 Mental Health Care Act. Now, in that, if the client says, "I want to go," you can't hold it. And torture centers, they highly misuse it. Minimum 6 months, they want to be a part of that treatment center. So this is another important thing. And even if you want to train them, where are the training opportunities available? Except AIIMS and NIMANS, you have online digital training, but this has to be in vernacular language, number one. Number two, it has to be accessible and affordable, and plus it has to go down to those centers. I'm not saying those quacks are bad or good, but at least if we bring them to our fold and start telling them, okay, at least you can, don't torture them, don't confine them, take them to a treatment center, let them get detox by a formal government setup, and then if you want to help them in recovery, please help. So that is important challenge. And the last is, we don't bother about quality at all. We always feel that, okay, if someone has been treated for 10 days, 15 days, 20 days, the person, those who have been using for 15 years, 20 years will be all right. So it is all revolving door. So they get treatment 10 days, 15 days, 1 month, they go back, and rehabilitation has to be integral part of any detox process. That is our conviction. Because what is rehabilitation? A person has been treated. Long-term pharmacotherapy, I agree what Dr. Rao has said. But if someone wants to go back to the normal life and doesn't want to use medicine for long term, for them, some rehabilitation services needs to be there, because whole person recovery is not possible on a short-term medical. Because we generally, what we do in a government hospital setting, we only provide the short-term pain management or short-term withdrawal management, detox, and after that the person will go back to the same milieu, same environment, same society, same neighborhood, and the people are waiting for this individual. Because we see with our kids, when they go back, we prepare them for 2 to 3 months that you will be offered drug, how you are going to ensure that you are not taking it. And the last one is, where is the recovery support system available? If that is not there, see, all of you are expert on this panel. Addiction, if they feel that, okay, let me try once again and I will be all right. At that one time, where is the relapse prevention or mentoring or recovery support system? So these are the big challenge what we face, and somewhere we need more NDTTC and NIMHANS type of organization to take the help of the smaller district level hospital, demystify drug treatment. I give you an example without naming the individual. See, we are also, we have been working in Punjab since 2002. Now a psychiatrist says, I will not treat patient with buprenorphine, I will treat only by tramadol. No, I can't help anything. See, somewhere there is a training gap. If a psychiatrist who has been providing treatment in a government drug treatment center for last at least 4 or 5 years and professionally trained, and if the person has so limited understanding what buprenorphine, we can't help it. So I'll stop here. Thank you.
Yes. Yeah. So I think the rehabilitation should be part of the process. This is not really we have to de-addict the person. We have to support him mentally, socially, and how to go back to the normal life. So I think Dr. Rakesh can tell us better that how can mental health and addiction services be better integrated within India's broader public health system to improve access and continuity of care.
This is a big challenge. Now, in psychiatry, we sometimes talk about severe mental illnesses and common mental illnesses. And substance use disorders, they come under the category of common mental illnesses. These substance use disorders are very common, and they often remain unrecognized. And so now the number of persons with substance use is so huge. So this cannot be tackled only by the psychiatrist. So we need to strengthen or say equip the non-psychiatric doctors, that are especially the primary care doctors, in treating substance use illnesses. And because now one approach which National Tobacco Control Program started, that you have a it was, I think, initiated by WHO. So asking one screening question to every patient who is coming in the primary care: do you smoke, do you use tobacco? So I think one more question can be added to that: do you use alcohol or any other drug? So, and this question does not require more than 10 seconds, and patient may not say yes or no, but this sensitizes that the doctor is interested, and this is a medical problem, this can be treated. This message goes, because if you start asking this question, and we tell all the doctors in the primary care, secondary care, asking this single question. So that's the one step. Once we bring it as a common mental disorder or common CMI or common mental illness or CMD, that's a approach. Second thing is, we have to spread a message or educate the public as well as the doctors, like it happens in any other medical illness, for example, diabetes, or if it's tuberculosis, or any other chronic infection or hypertension. Relapses are common in any illness. So same way, when you are treating a patient with alcohol use disorder, or you're treating a patient with heroin dependence, uh, treatment failures would be there, patient would relapse, patient would come back. So that should not dishearten the patient, no, should not dishearten the doctor or the family. So we need to tell that this happens in any illness, any medical illness. So that way, so that fear of relapse that goes. Otherwise, what happens is, you like for example at NDDTC also, or say you are treating as an outpatient. After 3 months, 6 months, the person relapses or starts using alcohol, say once in a week or once in 2 weeks. So we need to educate, we need to that this is not relapse, this can be curtailed, this can be treated. So that message also needs to go to the community, and because even doctors are also not, they are also ignorant. Like Dr. Bhat was talking about the COVID period at NDDTC, also Dr. Ravindra Rao had started online training programs for the doctors, and in which there are week sessions which they could take at different times. So that was so these kind of sensitization programs that can be started by the tertiary care institutions, like NIMHANS has been conducted on its own, and NDDTC, and so these can be taken at the state level institutions also. So by that, we can equip the doctors at treating treating these illnesses. So it's not necessary that if the patient, these patients, everyone should go to a psychiatrist or to the tertiary care center. And the another thing is that most cases of substance use, they can be treated as an outpatient. In fact, now I am working in a private medical college. This is a tertiary care hospital, and here I have been treating patients with this substance use, and rarely I have admitted the patients. And most patients who that use, generally I would be getting persons with the complicated medical issues who come to me, and I have been treating most of these patients as an outpatient. So it's possible to treat lot of patients. In fact, that's a cheaper method also, because if you admit a patient, that becomes the treatment costs also rise. So this was also realized by the Ministry of Social Justice when they were admitting, when they started rehabilitation centers, the patients would be kept for months together. So that's not a cost friendly. And at NDTTC, we found that especially in the at our community centers, where the patient comes and takes medicine in the morning, and then he goes for work. So that model has, I think, that was a very helpful model, and that has brought the patients back to the community, back to the families, and they have started working.
I believe that all the experts, they have emphasizing this fact that on OPD basis, these can be, addressed, and especially if you really want to bring down the cost. I would definitely like to touch upon that how automatic machines and tools are helping us, screening these tests, drugs better. So I would like to ask Dr. Ravindra that what do you think that how can automatic machines or tools for drug testing help us find substance use problems earlier, especially in rural or low resource areas?
Dr. Prabhat extensively mentioned about provision of treatment using modern methods like online, either Zoom, or Professor Chadda talked about our initiative at NETC where we had a self-paced online training program. So training is one area where some amount of focus has been given on using the modern technology to use. But in many places, like for example in the US and all, there are apps which also help in treatment of addiction. Some of them are also being developed in India, tested in India, but they are at very nascent infant stage. I believe that is something which is possible. Provide for example, screening a person whether he has a problematic alcohol use. So that is not a big deal, right? So that is something which is possible. There are validated instruments which are developed by World Health Organization, tested in different cultures, including in India. So something like audit, for example, alcohol use disorder identification test. That is a very easy to use tool. It is a self administered tool. So that can be something which is possible, which wherein screening can be done. Some online tools are also available where a person after screening then enters into basic treatment where some education about what is treatment, what kind of things to be done. So those things also are available. They have been tried out. So that is possible. Linking that person to a medical practitioner, that is there. And there are tools available which also helps you to log in whenever you lapse back, you restart using drugs. How to, when you get a craving, how to stay yourself away from drugs. So the online tools are also available which does this. So for example, in the area of tobacco use, smoking, that is something which many people use it online. And now with the kind of generation that we have, they find it out on the internet and they use it. And many of my patients, they come and tell that they have gotten extremely benefited by these kind of tools to stay away from smoking and to keep themselves motivated to continue the treatment, to stay away from smoking. And such tools are also available for alcohol or for other drugs as well. So utilizing such tools which are available free of cost. At some places they also are monetized, but there are also free of cost tools that are available which can be made use of. What we need is to adapt it to Indian settings. That is something which work has not been done much on that, and also to test the validity of or effectiveness of these tools in Indian setting. That is something which I think work is in progress. We need to work more, invest more on that front as
Thank you. Thank you so much. And Dr. Prabhat, what according to you, can be done to integrate automatic drug testing in community programs? And how can we make sure that the results are shared quickly with the doctor, with the policymakers and others?
Well, extend Dr. Rao's questions and sort of the question you asked, that how do a person in the community, because of stigma, does not seek a help with a counselor or doctor, and how he can assess, because he or she thinks I don't have an addiction. I mean using little bit. I mean, today I saw somebody whose families got him, and he's telling they forced me to come in because I have cut down the beer from 8 beer to 1 beer. I don't want to, but now families locked me, but I have to forcefully come here. So there will be a spectrum, because addiction is a spectrum. It's not a switch on, the switch on and switch off. I think that you are mentioning is very important. How do you get the people in a soft landing where they don't, you don't ask question, do you drink alcohol in my app? Many will just don't open the app, forget about opening the app. I mean, the biggest challenge in the app is you don't open the app. It doesn't matter what best app you world is created. So how do you make a soft landing to the person, to the system? And I think sort of as Rao mentioned that it's a big work. We in India has not done. I was just maybe I don't know whether I can share the screen. May not be possible, I think. But then I've just tested one of the maybe. Let me see if I is showing something. I'll just one minute I'll show you, and then I'll sort of yeah. This is the app. This is the thing. I was just putting my hand. Okay, is it visible by any chance? Can
No,
somebody
it's not.
not visible? Then forget about it. Then I think some problem. Leave it. I will put a link. So the challenge in the community was to target who are the people who are likely to use the app, possibly higher, and how do you put a soft landing? This is one part which always a challenge for all of us doing it. So regarding the investigations, first, so there, what happened? What I did in the app, I sort of test myself. It's in Oriya actually. It's Oriya app, it's local language. I test myself for audit alcohol use disorder 3 questions. I do it. I test myself. I found something and automatically get the WhatsApp or email. Now there is should be a some support which person can take round the clock. Fortunately, with Telemanas initiative that many of have heard of by Prime Minister Modi sir, that 14416 across round the clock it works across all states in India, all languages are covering. So now it's actually very good time to link the people. They assess by themselves. Like am I using a lot of gaming? I'm assessing myself. Okay, my use is not very heavy, maybe little lesser type, but can I sort of do some self therapy sort of thing, or I can call to 14416 where I can take help. For example, smoking, you have 180011235 so these type of things are coming up now in the country, which I think is very it's really nice to see, because a person can access the free help at any point of time if you wishes. Now the contact challenge is, can you do a soft landing for the person? Does the person want to open that? Specifically, he who is early users. I'm not talking about the addicted people. It is very visible. Look at early users, experimenting, adolescent boy, just experimenting here and there, but he thinks it's something. That is, I think, the thing. I mean, investigation wise, I think most things is self testing, like on the scales and find out mood and all. So, but then this is the way forward that people test themselves. Some group, not for everyone. If they find they're using excessive use, they got some self remedy. If it's more than excess, they call this number 14416, get some help. And now 14416 actually connecting doctors also now. Some state has launched it through e-Sanjeevani. 14416 takes the call. There will be mental health trained counselor. He understand the she or she understand the problem. She or he will help little bit, but when the red flag is there, like somebody suicidal, he or she connect to a district mental health program. It's still in that part is still going on. The connection is just started. But if this is crystallizes a little bit, I'm very hopeful. This is one big way to enter to the whole thing, and you can integrate the holistic health rather than looking at people like addiction, mental health, physical health, and this health that. It's not true, because my teacher tells me addiction is a pediatric disease. It starts from behavioral problem in childhood, inattention, impulsivity, and the path something comes up. My family has more access to gaming. He started gaming. I see my father drinking at home. Okay, I thought it's normalized, and few of them get too addicted. So I think this is the way forward. I think if it happens in 5 years, I will not.
Yeah, yeah. So I think we have been talking about training. We have been talking about asking questions. Um, what I want to emphasize on that, are there any tests available? Because I'm a pathologist, I'm more interested in what I get through the tests. So are there any tests available that can be made available to the public, especially in the public health program? Dr. Rakesh, if you would tell us.
Uh, I think Dr. Ravindra Rao is a more suitable person to tell about it.
Anybody. Dr. Ravindra,
I
your comments?
Yeah, I understand what you're trying to say. See, there are drug testing laboratories, and there are nowadays cassettes that are available, like you do for check for pregnancy. Similarly, you check for drugs. So drug screening
Yeah.
cassettes are available. Compared
Yeah.
to earlier, now they are very cheap, and you can test. Uh, the biggest advantage is that it is available, and you can do it. It gives you within minutes whether the person is using drugs or not. But the biggest limitation is it will just tell you whether in the recent past, which is the last couple of days or a week or so, whether the person has used that particular drug. Different drugs have different time span where they can be detected. That's it. It will not tell you whether this person is suffering from substance use disorder, or if he was using earlier but now not using this. Like, for example, we have Dr. Prabhat mentioned about a person who was forcibly brought, right? So we have such patients who are forcibly brought. What they do is in the last 1 week they will not use the drugs, and then they will come, the parents will say that please order a drug screen for him. So we know that that person. So that kind of thing can be done. Self testing is something which is possible, but self testing will not be helpful because the person himself is aware whether he has used drugs or not. Now the parents can use it. At times, employers nowadays they have started screening for drugs. So those kind of things, how much they'll be useful, not useful is something which is for us as clinicians. They are very helpful in rapid detection of drug in body fluid, especially in urine, which is the most common body fluid that is used. But we need to understand the utility and also the challenges or the limitations with such kind of a test. So that is something which I want to mention here.
That's great. And on that note, I think it requires a holistic approach. I believe that not only testing, but training, educating, the social stigma around it, all these things should be busted. And we should have more and more community-based programs to support youngsters, especially who are just falling into the grips of addiction. And I think that can be done if we do something collectively. Thank you all for joining today in this important discussion.
I think
Thank you.
thanks to Lisa and Voice of Healthcare taking this such an important issue. We are looking at the website. There are a lot of cardiac things and all, but I think it's a great that you and your team think tank thought about this issue and bring it forward. It itself is a big thing. I think Dr. Rahul agree with me that it itself looks some bright future, bright thing for the country and for the community. Thank you.
Yes,
Thank
I echo your thoughts.